Hello, everybody. I'm Harald Meden and speaking from Switzerland to you. I want to give you a warm welcome to our webinar. I was asked to make the introduction to this webinar and to introduce the speakers. It's a great honor for me and a great pleasure at the same time to do so and to follow this invitation. We're looking forward to an exciting webinar. We have more than 400 participants at the moment at this webinar, and a lot of more will see this after the live stream. We do have participants from more than 100 countries from all over the world. I want to tell you how we have organized this webinar. It will last 1 hour, and the first 40 minutes will be dedicated for the speakers to give their presentations. We have 2 presentations with 20 minutes each. Afterwards, after the 2 presentations, we will have 20 minutes time for your questions and the answers to both of the presentations. So menopause is the topic that gathers us today. Menopause is an important phase in every woman's life. Menopause is not a disease, but a time of change. Menopause is experienced very individually, and patients in menopause can be divided into 3 groups. First, those who do not have any complaints. Second, those who do have complaints, but they can afford, they can manage, they do not suffer from them. And third, the women who do suffer from menopause symptoms. What can we do? What can we offer? And what could be an alternative to hormonal treatment? This is the frame in which we will move in the next 60 minutes. And I'm happy to introduce and to announce the presentation of Professor Camil Castelo-Branco from Barcelona, Spain. And he will give us current information and tell us an update and meta-analysis of clinical data on a unique guideline recommended herbal extract for menopause symptoms. Dear Camil, we are looking forward to your presentation.
Thanks, Harold, for your presentation on my topic. Good morning, afternoon, or even evening, depending on where you are at this moment. It's my great pleasure to take part in this symposium on the evidence-based non-hormonal treatment for menopause. So as the audience will know, we are in a sponsorized symposium by Sharper and Blumer. And in the next 20 minutes, we try to develop this agenda, devoting the initial minutes to clarify some aspects of herbal medicine and recommendation of scientific societies for later explain the new data on studies on isopropanolic Semicifuga racemosa studies. Here is the star, Semicifuga racemosa, also known by several nicknames, Actaea racemosa or black cohosh. What is important is that it is important to highlight that the rootstock is the key for medicinal use, that the rootstock does not contain phytoestrogens. Originally, this was used by as a gynecological remedy by Indians, by Native Americans, and eclectic physicians, with the first studies appearing in the first years of the 17th century. The first herbal medicine product based on Simicifora racemosa was born in Germany in 1956. Since that moment, the extract has had a worldwide distribution. And at the end of the last century, a fixed combination with high dose of isopropanolic Simicifora racemosa extract with Hypericum was approved as a medicine, as herbal medicine product. And I am going to take the time to briefly describe the characteristics of phytotherapy before explaining other aspects of this lecture. Since herbal products, even if they are from the same plant, may differ significantly regarding their active compound. The active ingredient of any herbal medicine product, any herbal medicinal product, is the total extract. The total extract is a multi-ingredient mixture. Therefore, the composition of one extract, even of the same plant, varies depending on many factors, such as cultivation and harvest condition, extraction process, extraction agent, etc. No one doubts that different composition leads to different effects and efficacies. There are studies studies with one specific extract cannot be transferred to other one, even if we are dealing with the same plant. And here is an example of how different are the effects of the same extract, just with a different time of preparation. Only few minutes of difference may lead to real different effects. As you can see, just 3 minutes with black tea is enough for wake up us. But if we stay more than 5 minutes, the composition of this extract differs and the effect are clearly different. In 2015, the National Institutes for Healthcare Excellence published the menopause guidelines and elaborate a meta-analysis assessing the efficacy on vasomotor symptoms of 12 different treatment classes. And this project included up to 32 randomized clinical trials. And the results demonstrated that among the non-hormonal therapies, black cohosh has the strongest treatment effect on and the highest probability of being the best therapy. Moreover, black cohosh and transdermal hormone therapy had the best relative treatment effects and were the only two treatments that significantly better than placebo in this meta-analysis. And it's worth to highlight that that among the non-hormonal therapies, Simicifora was the only one with significant effect, more effective than placebo. The nice conclusions in the guidelines state that black cohos are black cohos are clearly positive, stating that black cohos showed significant efficacy compared with placebo. However, these guidelines made a warning on the results of not only for cymicifuga but for all herbal medicine products, advising that they should be interpreted with caution as the variety of herbal preparations may differ significantly. Therefore, we can think on which preparations can be recommended. To answer this question, at the beginning of this year, the German-spoken societies of Obgyn published their own guidelines on menopausal management. And they conclude that the benefit of, that the cognitive behavioral therapy, isoflavones, and black cohosh preparation can be used for treatment of vasomotor symptoms, but also highlight some risks of these therapies. However, the German Society, the Society of Phytotherapy, highlight the need to differentiate the different herbal medicinal products from food supplements, and also the need to differentiate the different herbal medical compounds between them. And this is important to take in mind, because as I told you before, the different structure procedures or different harvest condition or different systematization of production may lead to different effects. On 2013, BNF published this meta-analysis showing the significant efficacy of the isopropanolic extract of Cymicifuga racemosa, and with a level of evidence 1B, and that is clearly superior to the other products made with the same extract. But from 2013, many papers have been published, and for this reason, we perform, a new meta-analysis and systematic review. All clinical studies with isopropanolic Cymicifuga racemosa extract, as well as the fixed combination with the Hypericum perforatum from the early 16th to the January of this year, what is included in this meta-analysis and systematic review. All available randomized placebo-controlled clinical trials were included in this meta-analysis. And we record also the efficacy for neurovegetative and psychological and climatic symptoms, as well as the occurrence and frequency of adverse events, as well as undesirable effects. And in this meta-analysis, we consider more than 43,000 patients were included in this meta-analysis, of which more than 13,000 patients were treated with the isopropanolic Cymicifuga racemosa extract. And all of these studies show a clear positive effect compared with placebo, and the overall results are clearly as expected, was clearly positive. So we have demonstrated that the isopropanolic semi-simple racemose extract is clearly superior to placebo and is useful for treatment vasomotor and psychological complaints. But the next step is to compare with the standard hormone therapy. In this case, this is a randomized clinical trial that include more than 200 patients comparing our extract with Tibolone. And what we observed was that the effect on on Cooperman index was just the same when compared 2.5 milligrams of Tibolone with 40 milligrams of isopropanolic extract of Cymicifuga racemosa. So the same efficacy was demonstrated, but when we look for adverse events, and specifically the gynecological bleeding, 0 patients on Cymicifuga present bleeding during the study, whereas 27 patients with Tibolone show disruption during this period, during this 12 weeks period of the study. So we have the same efficacy, but a better safety. And we can conclude that from this study that the specific isopropanolic semi-simple racemose extract has a significantly better benefit-risk profile than Tibolone. However, Tibolone is not the standard therapy for menopausal symptoms, and in this study done by Rosella Nappi in Italy, they compare small numbers of patients with isopropanolic semi-simple racemose extract with low-dose transdermal hormone therapy. In this case, was the same dose of Cymicifuga, 40 milligrams, and was compared with 25 micrograms of transdermal estradiol. And in this study, in fact, the most important limitation is the scan number of patients, just 64. But in this study, that is also a randomized clinical trial, they found the same efficacy on hot flashes on vasomotor symptoms, as well as the same efficacy on anxiety and depressive symptoms. And we can conclude with the level of evidence 1B that Cymicifuga racemosa, these doses, and with this specific isopropanolic extract, may be a valid alternative to low-dose transdermal therapy in the management of climateric complaints for those women who cannot be treated or that just refuse the hormone therapy. The other question is for how long we can use Cymicifuga racemosa as a treatment for menopausal complaints. And this is a study up to 12 months made by Bryce, that they show that in the first 6 months, progressive improvement was obtained. And after that, the patient showed a constant efficacy. This drug doesn't lose the efficacy across the time on this study. And what is interesting also in this study is that when we combine with the Hypericum perforatum, higher improvement on psychological symptoms was observed. Both doses of Cymicifuga show a positive effect and improve significantly the menopause rating scale, but when we use the fixed combination with the Hypericum perforatum, higher increase was observed on the psychological symptoms. Other aspect that was controversial is the safety of the Cymicifuga racemosa products. As many of you can take in mind, 10 years ago, several news warning on the effect on liver with these products was published on the papers. But to answer this question, in 2011, Nasser colleagues performed a meta-analysis with the specific isopropanolic semi-civic racemose extract that is an herbal medicinal product, and include more than 1,000 patients in this meta-analysis, and they found no evidence for hepatotoxicity with this specific herbal medicine product with a high level of evidence. What is the summary of the safety of these herbal medical compounds in the clinical studies? Well, the treatment is generally well tolerated with few minor adverse events or even no adverse events. Compared with placebo, the frequency of adverse events under this specific extract was not significantly different. The higher doses of the isopropanolic semi-civic racemose extract demonstrated the same good tolerability as the standard dose. This is to note to comment that when we use the fixed combination with the Hypericum perforatum, the dose of semi-civic is slightly higher than when we are using just the pure compound. And finally, no significant influence of this specific extract on body weight, body mass index, heart rate, blood pressure, and other security and safety criteria was found with the use of the isopropanolic semi-civic racemose extracts. Just to conclude, the efficacy, as I show in this presentation, the efficacy of this specific extract, excuse me for use many times the word specific extract, because this is important when we are talking about semi-civic. So the efficacy of this isopropanolic semi-civic racemose extract or the fixed combination with the Hypericum perforatum for menopausal symptom is significantly superior to placebo. The efficacy is comparable to Tibolone and to low-dose transdermal hormone therapy, and due to its better tolerability, this extract had a significant better benefit-risk profile than Tibolone. For psychological symptoms and sleep disorders, the fixed combination with the Hypericum perforatum is significantly superior than the single use of semi-civic racemose. And finally, treatment with the isopropanolic semi-civic racemose extract is well tolerated with only few minor adverse events. These adverse events have a frequency comparable to placebo. And the clinical data and all the meta-analysis done with these specific extracts don't reveal any evidence of hepatotoxicity. Therefore, as benefits clearly outweigh risks, both compounds could be recommended with a grade A of evidence as a treatment option for menopausal symptoms. And just that's all.
Dear Camil, thank you very much for your excellent presentation and for giving us an update on the latest scientific data. We are now making a jump across the Atlantic Ocean and go to the United States. It's a great pleasure for me to introduce the next speaker. We go to Yale University to Professor Mary Jane Minkin, who is awaiting us there. And Professor Minkin will give us a presentation on the benefit-risk profile of isopropanolic black cohosh extract, ICR, in patients receiving endocrine treatment after breast cancer. Mary Jane, the floor is yours.
Thank you so much, Professor Midden. Greatly appreciated. So let's see if I can get the technology to work here.
Okay, we will help you if necessary.
Hey, I think it worked. Okay, so I want to thank everybody for asking me to be with you, and it is a pleasure to discuss my topic today, which is let's see if I can go to my next slide here. There we go. To talk about the specifics of isopropanolic black cohosh extract, ICR, that I'll keep to the abbreviation most of the time, in patients receiving endocrine therapy after breast cancer. And you can see on the slide sort of where my interest is. I've always been interested in women with breast cancer and other cancers, and as far as treating them with menopausal symptomatology. And even without endocrine therapy, in the old days, before we used tamoxifen and before we used aromatase inhibitors, women who had breast cancer suffered from significant menopausal symptoms because they were getting, either they had been on estrogen and had to stop taking it, or they were being given chemotherapy. And so women developed significant symptoms. And what did we have to treat them with? And that's why I developed my interest years ago in isopropanolic extract of Semisufusa racemosa, because it's such an important product and really had great benefits for our patients. And so, and you see, about a dozen years ago, we founded the Sexuality, Intimacy, and Menopause program here at the Smilow Cancer Center at Yale for treating patients who have these issues, so longstanding issues. And I do consult and speak for our friends at Shopper and Broomer. So we're going to talk a little bit about the background and then advance to clinical studies in breast cancer patients and those pertaining to breast safety, of course, which is paramount in our interests. We'll talk about some of the experimental safety data, and we'll also talk about some of the chemical interactions of both ICR and St. John's wort HP with interactions with regard to the metabolism of the endocrine therapies, because that's something that comes up all the time. Is ICR safe to use, or ICR with HP safe to use in women on tamoxifen or aromatase inhibitors? And we'll have let's talk about some conclusions and then hopefully have some time for questions. We do know that treatment with tamoxifen often causes hot flashes, sleep disturbances, depressive moods, irritability, and mood swings. That goes for women without tamoxifen too. And if you add aromatase inhibitors, it's even worse for most of them. And the other thing we know as clinicians, that if you have a patient who's suffering from a significant burden of side effects, she's much more likely to stop using that therapy, and particularly if it's an endocrine therapy that's bringing on the problems. And we want these women taking their endocrine therapies because that enhances their cures. So we want to be doing the best we can to minimize the side effects here. And we do know from a lot of data that both ICR and ICR alone and with HP does improve neurovegetative and psychological menopausal symptoms without having hormone-like effects. And we're going to talk about this extensive safety data for ICR and ICR with HP. Got a nice picture of the plant here. And the important thing for ICR is that there's really no known interactions for ICR with just about anything. And this has been used for decades, as you know from Dr. Castelo-Branco's presentation, and there have been really no significant interactions known for the ICR special extract. The other question that has been questioned for years, especially in the breast cancer community, is do the black cohosh rhizomes have any phytoestrogens? And unfortunately, as Dr. Castelo-Branco has already told you about, that not all black cohosh is ICR, and especially in my country, but I do know, unfortunately, in your countries as well, that you may not get the purified product. People will say they've got black cohosh, and it may not have any black cohosh in it, for one thing. And there are a lot of contaminants which may have phytoestrogens, but not in the ICR product that we're using here. And the other thing, we have good data, which we'll talk about in a minute, that the ICR does not influence hormone values. If you had something that were phytoestrogenic, we would expect to see some changes in FSH, LH, estradiol, prolactin, sex hormone binding globulin, or looking at endometrial thickness. And we don't see those with the ICR product or ICR with HP. So again, you can infer that these things are another background for why these drugs are safe, or why this extract is safe for women with breast cancer. And again, we will also show some slides about ICR not affecting breast tissue, which is very important to our patients, our normal patients as well, not our patients just who are suffering from breast cancer. Because women these days, particularly since in our country's contribution to the world of the Women's Health Initiative, who have been terrified about using estrogenic products and affecting breast tissue, we can say, hey, we have good data here. This does not influence breast tissue in normal women, as well as women who have breast cancer. And you can see this is from Professor Hirschberg's paper from a number of years back. And so some basic studies that you can see, this is observer blinded open study, 74 healthy ladies with 6 months of the typical dose of ICR. And you see the baseline, you see the 6 months, there were no significant changes in mammography, and also using studies on proliferation markers such as Ki-67, which we use to study breast cancer, no significant changes in Ki-67 activity. One of my friends at Yale here has been conducting a study on that as well in breast cancer cells. And indeed, none, in Dr. Hirschberg's paper, none of the women showed any increase in mammographic breast density. Further, there was no increase in cell proliferation. And indeed, this finding suggests that ICR does not cause adverse effects on breast tissue. And this was a sort of hallmark paper published in Menopause in our country, which showed safety in the breast. This is another study about not quite 10 years old, which is a prospective observational trial with women on tamoxifen for breast cancer after primary therapy. And then they were started with the standard dose, 40 milligrams per drug per day, with drug dosage is adjusted, and you can use more or less of the ICR if you want to, looking at assessments both for adverse events and menopause rating scales. And indeed, what's interesting is the menopause rating scale total score decreased significantly, with the best improvements noted with hot flushes, sweating, sleep problems, and anxiety. And what are our patients suffering from? A lot of them, and particularly you throw in COVID on top, guess what you're dealing with? The responder rate was quite good, 70% at last observation. And there were people who did report adverse events, but they did not seem to be linked to the ICR, with 90% of the patients judging the tolerability as good or very good, and nobody is bad, and nobody in the study had recurrences. And if you look here, in the ICR use with the menopause rating scale subscales, what were we talking about? The particular improvements, and you can see month 0 in the dark blue with a significant improvement in vegetative complaints and psychic complaints, which is what we would anticipate seeing. So indeed, this study confirmed that. So again, decreases in hot flushes, sleep disorders, mood, irritability, anxiety, physical and mental exhaustion, and our patients are getting that now, plus COVID. So it's a good drug for now. This is a very interesting paper, which was done a number of years ago. And what you're seeing here is a study of the database. It's an IMS disease analyzer database, and this is a large pharmacoepidemiological cohort study that looking at patients after primary breast cancer, isolating those who had ICR alone or ICR plus HP, and a study that went on basically about 10 plus years. The overall observation time was 3.6 years, with variation going from 6 months up to greater than 9 years. And these are people not with metastatic breast cancer, unclear recurrences, and these women were not using any other CR products. These were women who were just using the ICR and the ICR HP products. What do the results show? Which is very interesting, and I have a couple of slides to go on with this, with, again, significant exclusion of any increased risk. But what they saw not only was no increased risk, which would be good enough to say, hey, I've got something that takes care of symptoms for these women, and it doesn't increase risk. But the interesting thing in this data, it actually showed mean risk reduction, or the other phrase that I like to use when I talk about this here in this country. There was an advertisement many years ago for a bread product, I believe, and the motto was good and good for you. So this is the kind of thing that I say, good and good for you. ICR and ICR plus HP were not only safe in the therapy of menopausal symptoms in breast cancer, but there may be some extra advantages. And what you see on this chart, it's sort of like looking like a Kaplan-Meier plot of recurrence-free survival. And what you see is in the blue, you see the women who received the isopropanoic extract, and then you see the women who did not. And again, this is a registry. This is not prospective randomized data, but you see an improvement. And what you see here is that for the ICR group was a longer average recurrence-free survival, which is, again, people are looking for safety, but if you can get a benefit too, that's pretty good. And indeed, what you saw was a 4.5-year longer recurrence-free survival. Pretty good data. Okay, so let's talk about some experimental data, not just patient data, but experimental stuff. So what do we look at? And these are some cells looking at breast cancer cells, human breast cancer cells, MCF, MDA, MB. And what you see here, ICR exerts estrogen antagonistic effects and dose dependently inhibits the proliferation of breast cancer cells. So maybe there's some lab data that we can say maybe giving us some explanation to what we saw clinically. And one thing that's been shown shown is that ICR seems to inhibit the growth of estrogen-dependent and independent growing breast cancer cells by caspase activation and apoptosis induction. And that's, how do we explain these good things happening? And it seems that in the lab studies, ICR reduced the invasiveness of breast cancer cells and may increases the efficacy of tamoxifen, which may help account for this. And the other thing that's been shown, and this is a Professor Stutz's data, that ICR reduces estrogen production in breast tissue, possibly by inhibiting steroid sulfatase activity. So all of these are some lab in vitro type data, possibly serving as an explanation for why you see the good results that we're seeing clinically. There are also some animal models with Sprague-Dawley rats, DMBA breast cancer animal model. And we have seen in these that, and this is some old data, that ICR does not stimulate tumor growth. And there's actually a trend towards decreased growth. And actually, if you use the ICR early, prepubescent application of ICR actually resulted in reduced tumor growth and a longer lifespan. ICR does not increase tumor growth, and it actually seems to enhance the efficacy of tamoxifen. The combination of ICR and tamoxifen increased the incidence of tumor-free animals and reduced the individual tumor burden. And again, this is in the experimental rat data here, okay? And again, tumor growth and anti-neoplastic effects of the aromatase inhibitor formestane were not influenced by ICR. So all this stuff is good. Now, if we go from just the ICR extract, what if we add St. John's wort, which is well known to many folks throughout the world as a mood enhancer here. And women, again, with breast cancer are unfortunately maybe well prone to these problems. There are no known interactions between St. John's wort in general or between the ICR HP product and with efficacy with people taking endocrine therapy. No endocrine interactions, and we'll talk about some data there. That does not cause the St. John's wort extract in the particular product does not cause clinically relevant interactions. And if we look at tamoxifen, basically warnings in the tamoxifen template summary or product characteristics that we are advised, and this is one thing in treating breast cancer patients who have mood issues, and of course there are people that we are using SSRIs to help with hot flashes, that one of the warnings is don't use CYP2D6 inhibitors, because then those drugs we're talking about are things like paroxetine, fluoxetine, which are drugs that folks have used for hot flash therapy off-label in the US, certainly for hot flash therapy. And we know we do this because tamoxifen is probably not your active thing that's out there taking care of your breast cancer, that basically it's the product, the endoxifen, which is the metabolite, which is the active metabolite. And if you have an inhibitor, you end up with less endoxifen. Well, if you can end up with more endoxifen, maybe that's a good thing. And for example, if you look at something like rifampicin, which is a strong CYP3A4 inducer that reduces tamoxifen concentrations, but again, it's not considered necessary because again, you're not messing with the endoxifen necessarily. So this is for the chemists, the biochemists in our audience. If we look at the prodrug tamoxifen, and of course at the bottom we have the most important active metabolite, as I said, which is the endoxifen, and that you have the first, basically about 90% of the tamoxifen first that goes through CYP3A4 and 5, about 10% through CYP2D6, and then you end up going through the different metabolites to endoxifen. And what you have here is the CYP2D6, as we said, may inhibit, and you end up with less endoxifen. But when we throw in St. John's wort, which does not have an influence on CYP2D6, but may induce CYP3A4, does that theoretically, I said theoretically, increase metabolism in the active metabolite endoxifen? Certainly a consideration. And again, if we go back to the safety of the women who were using the ICR or ICR plus HP from Dr. Henneke von Zeppelin's data, what you see here is the tamoxifen plus the ICR plus HP on top, which is better recurrence-free survival. And you see the line below is the tamoxifen. So we may have some biochemical explanations for what's going on here. So these are possibilities. The result was independent of whether the ICR was monotherapy or whether it was with St. John's wort. And again, what do we have here? And a lot of the data we've talked about is with tamoxifen, but we do know that we have many women these days who are taking aromatase inhibitors, which may actually induce worse symptoms that women will be experiencing, not only of hot flash, but neurovegetative symptoms of sleep disorders, mood disorders. And what you see here, and I'm not going to go through everything, you can look at the slides again later, as far as the different pathways from anastrozole, letrozole, exemestane to the metabolites. And so what you end up seeing here, though, is that there are no known influence of potent CYP inducers on anastrozole metabolism. Safety data analyses and clinical studies show no significant interactions with commonly prescribed medications. CYP2A6 is the primary clearance mechanism here in letrozole, with no significant interactions of HP with letrozole are expected. And again, with exemestane, the clinical relevance of exemestane area under the curve reduction by rifampicin, which is a potent CYP3A4 inducer, has not been clarified. But again, that there's been no, for HP with ICR, no interactions with exemestane have been reported. So again, there's questions of whether to check estradiol levels and adjusting doses, but certainly from a safety perspective, you can use these meds. And again, there's some data suggesting that St. John's wort interactions suggest on the dosage and the hyperforin contact. So again, if you have a high dose and hyperforin rich extract, these are the interactions that are primarily mediated by the CYP3A4 and glycoproteins. Again, just some information on hyperforin with metabolism of xenobiotics, and the hyperforin content in various German St. John's products varies greatly. But again, if you have a low hyperforin content, it has no relevant increase on 3A4. So again, what we see in the data we have from the ICR plus HP product, no clinically relevant interactions with the HP extract in the fixed combination we're dealing with in ICR plus HP. And we have here to back this up, 2 double-blind randomized placebo-controlled studies. The intake of the HP constituents corresponds to the maximum dose that's seen in the ICR HP product with 2 times 2 tablets a day. These are some data with measurements. I'm not going to go all of this in detail to give more time for questions here, but what you basically see in the results are no significant differences between the HP and the placebo product regarding any of these issues as far as metabolic issues, so that we can basically say that the HP induced changes is less than 12% of the initial median area under the curve, therefore not clinically relevant. So what are our conclusions for our patients who are undergoing not only tamoxifen, but aromatase inhibitor therapy? Most breast cancer patients with tamoxifen-induced menopause symptoms benefit from ICR treatment. And again, as far as interference potential, the tamoxifen users could actually benefit possibly by an even higher dose of ICR or the combination of ICR plus HP. ICR does not contain phytoestrogens to make our oncology colleagues comfortable, does not influence hormone levels. We have that data. ICR does not influence breast density or breast cell proliferation, and that patients after breast cancer, also tamoxifen users who are treated with ICR alone or with HP, have significantly longer recurrence-free survival, getting back to the good and good for you. And again, we've seen that the St. John's wort extract, that you don't have to worry about clinically relevant interactions. So you can use it without worrying about the metabolic effects on their hormonal therapy. And again, I feel comfortable with this and prescribing this for my patients for years, recommending it. The benefit risk profile of ICR and ICR plus HP for patients after breast cancer is positive, and ICR alone or ICR plus HP can be safely recommended to docs to these patients. And the compliance of patients suffering from side effects of endocrine therapy could be increased by recommending these products, ICR or ICR plus HP. That again, we want our patients adhering to their therapy. It's going to make them better for longer time frames, and we'd like them to be able to be comfortable while they're doing it. So thank you so much for your attention. Thank you for inviting me to be here. And we're going to throw this open for questions. And obviously, I think it's going to be more questions than we have time. So you can email questions to the email listed here, or the scan to QR code to mail directly. And again, thank you very much.
Thank you very much, Mary Jane, for your excellent presentation and for taking us with you, making a journey through the world of menopause in breast cancer patients and possibilities to make an efficacy treatment. So we are now switching to the last part of our webinar today, and I was asked to chair the next part, questions and answers. And I see some questions have already come in, and perhaps Mary Jane, could you point out what is HP?
Hypericum perforatum.
Right, Hypericum perforatum. This was not quite clear to one of our participants. I'm sorry for bothering you with that abbreviation. So we do now know what it stands for. Then there's another question. Perhaps you may continue. Is there any interaction with the estrogen receptor when using ICR?
The answer is not that we're aware of.
Okay, so this is an important information because all of us do know that breast cancer patients are often afraid to take anything that could reactivate their disease. So hormones are not appropriate, we do know that, and they ask for alternatives. And even with those alternatives, they are quite critical, asking, could it do harm to me? And so it's a very important matter that you have addressed now. I'm looking for the next question. The next one is addressed to you too. Hazard ratio was interesting, wonderful. Can you explain the 0.827 hazard ratio and its confidence interval? Quite a specific question. I think it was taken out of the context, and perhaps you may take inside again.
I'm sorry, was that the computer sort of froze here?
So we can switch to another question, and this is the question to. Perhaps you do not need your slides for the next question. HP acts on cytochrome P450. Do we have to consider that when prescribing the isopropanoic extract?
Has not been seen clinically at all as far as an effect.
Okay. And another question is, what daily dose of cimicifuga racemosa is optimal for controlling the menopausal symptoms?
Well, typical dosage is 40 milligrams a day. And the typical ICR product, the recommendation is 1 tablet twice daily, although there are other ways to take it. However, one can reduce dose, of course, and you can actually go up to a total dose of about 120 milligrams a day, depending on symptomatology.
Okay, thank you. The next question is addressed to Dr. Branco. Excited to see the herbal effect on menopause. Can you explain, does it go with food restrictions, like to avoid some vegetables like bitter gourd, sesbania, gran flora, like leaf, and non-vegetable, and the BMI and past history of disease restrictions? This is a question from Professor Raja Gopal from India to you, Camil. So, should we change food while taking cimicifuga racemosa, the isopropanoic extract?
Yeah. Apologies because I have my micro off.
Sorry, should I repeat the question?
Yeah. No.
When taking ICR, should we change our meals?
Yeah, most of these products that you put in the question are rich on phytoestrogens. So cliff is it's also very rich on phytoestrogens. The restriction on cliffs is not a problem on the effect of cymicifuga. Is the mechanism of action is clearly different. We are dealing with a product that that is demonstrated that doesn't interact with estrogen receptors.
Okay.
So I don't see any problem in the use of cymicifuga in a person who has some dietary restrictions. I think that the effect of cymicifuga is the same, even if you are a vegan or if you eat meat. I think that this is not a question.
Okay, thank you very much. The next
And
two.
regarding let me, I wish to highlight when on the last question that I agree with Mary Jane that the standard dose is 40 milligrams. That is that this corresponds to 2 tablets per day. But when we use the fixed combination of with Hipericum perforatum, the doses is higher than 40, is close to 70 per day. And in the meta-analysis, we demonstrated that higher doses are even more effective. So
Okay.
I think that 40 milligrams is the standard dose, but if we need, we can increase up to 70 with the guarantees of safety.
Okay, thank you very much. Another question is addressing the abbreviations. ICR, I want to give a comment on that. CR does mean Cimicifuga racemosa, the name of the plant, and I, the first letter in that abbreviation, means isopropanolic, and this means the kind of extraction, and this means the kind of alcohol which is used to extract the compounds the compounds of that plant. There's another question from Marion Stewart asking, on average, how many weeks or months are the clinical trials seeing the static therapeutic effect? Camil, could you give a comment on that?
Yeah, most of the studies are on 3 months, but we have one study with a follow-up up to 1 year of follow-up, showing that after the 6 months, we maintain the efficacy. So the clinical trials are done until 1 year.
Okay.
But that doesn't mean that the period of use should be limited to this 1 year. We can use cymicifuga for long periods of time with the feeling of safety.
Okay. So Mary Jane, the next question is from Bangladesh, asking what is the source of ICR and HP?
Okay, can I actually add one thing to Camille's last comment here about duration of therapy? That one thing that I encourage folks, even though you can obtain ICR without a prescription, that doesn't mean that people shouldn't be monitored. And that I hope that, and if you look at some of the packets, at least they're available in the US, that it talks about use for 6 months and then restopping and restarting. And really it's to evaluate efficacy. And we want people to be under the care of a care provider. Obviously my breast cancer patients, they're getting taken care of regularly. And again, if you look at clinical trials and data, that if you look at estrogen data, you really are dealing with a year's worth of data there at most in general. There aren't really 10-year follow-ups. So we have similar data for the ICR product. Okay. And as far as where the product is gotten from, actually, as Professor Castelo-Branco talked about in his initial slide, that actually the product of Cimicifuga racemosa actually comes from the US. It's a Native American plant, and the product is obtained here from special sources and brought back and formulated in Germany. As far as the HP, this is also a product that's used in Germany regularly. And again, from a regular source, because we know that concentrations of things vary as far as where you get the product from.
Okay, thank you for information. The next question is addressed to you too. It's coming from Australia, from Dr. Jerry. And Arturo Cherry wants to know, is CR better than isoflavones in the management of vasomotoric symptoms in the field you had addressed?
Okay, how many hours do I have for this question? This is, thanks, Professor.
We have finally 3 minutes.
Okay, I'll take a few seconds then here, because this is a very long.
Do not consume all those 3 minutes remaining
I won't.
in our webinar.
A few seconds.
Okay.
So basically, as far as efficacy, there are no head-to-head comparisons of ICR versus isoflavones. In clinical experience, I in general personally think, and I think most people have noted, that ICR works better as far as the efficacy for vasomotor symptoms, mood, etc. Okay, but the thing is that in a sense, it's what do my oncologists care about? Because I can tell patients anything I want, but they're going to go back to their oncologist, so I beat them to the punch and I go to the oncologist first. And most oncologists are happier with the thought of ICR versus an isoflavone, because at least in this country, in the US, a lot of oncologists get nervous about isoflavones, saying, oh no, that's bad for their breast cancer. Now, we know that may not be the case, but many oncologists are concerned. So I think it works better, the ICR works better, but also we have less anxiety from oncologists, at least from oncologists who understand ICR. So.
Thank you. And there's another question addressed to you.
Hello, I wish to highlight one point on the comment of Mary Jane.
Okay.
I think that is important to highlight the fact that isoflavones interact with the estrogen receptor, and in patients with breast cancer may have a competitive action with patients who are taking tamoxifen. And this is another reason to use ICR.
Okay.
We have no competition with tamoxifen. And another question is that among all the non-herbal products, simicifuga was the only one that showed in meta-analysis a superior efficacy to placebo. I think that we have two good reasons to prefer simicifuga than isoflavones in patients with breast cancer.
Okay, that is a good point. In addition, would you please continue, Camille? Next question addressed to you. Post-breast cancer situation. Can the patient use Livial as her, because ICR did not have with regard to bone and tissue protection? What about Livial?
Yes, I know, Livial is Tibolon. I know.
Tibolon, right.
Yeah, Livial is Tibolon, but they are, in fact, Tibolon has an important study whose name was Liberate to use the Tibolon in patients who survivals of breast cancer, and they closed the study because the high incidence of reincidence of breast cancer in these patients. Therefore, Livial is contraindicated in patients with that survival to a breast cancer.
Right.
You cannot use Livial.
Okay, it is contraindicated, and we do know that is increasing the risk for new breast cancer and for recurrence of pre-existing breast cancer. So the answer is no. So, sorry, time to say goodbye. Our hour is finished now. I want to thank the speakers for the excellent presentations. I want to thank BT Congress for running this session and for the excellent technical performance that we had and that we could profit of. I want to thank the company Sharper and Brömer for initiating this very important and current topic. I think we could share a lot of thoughts, opinions. We should get a lot of answers to current questions. There are still some questions remaining that have not been answered. And you can put that question to those questions to the email address that has been shown before. Mary Jane, after starting additional participants came into the session. Could you show the slide again before we
Sure.
show the last slide? The slide with
So
the
let's see if
email
we can get
address.
that up. Hang
Right.
on one
Slide
second.
with the email address where
No.
participants
And
will be able to address
let me get that
questions
slide up here. Okay,
in a post-session way.
here we have it right here. Okay,
Good
here we go.
slide.
Let me get
Okay,
it defined.
fine.
Here we're good. Anybody, please take a look at that slide. Yes.
Okay, thank you very much. So to all participants of our webinar of today, please have a look on this pre-final slide for all those whose questions could not be answered due to the restricted time that we are able to use. Please address your question to this email address and you will get an answer very soon. So I want to thank the participants from all over the world for having taken part in our webinar, for your interest, for being here, for sharing the thoughts with us. And we have a final slide, which I would like David to put in. So we have a final announcement for the next event, and this is from the International Society of Gynecological Endocrinology. And this will be the 19th World Congress, which will take place in December, so very soon, 2nd to 5th December 22. And this will be held as a virtual Congress. And all of you, you are invited to take part and to continue this discussion and to address again the topic and other very interesting topics in gynecology and endocrinology. So sorry, our time is up. Thank you very much to all who took part here and made it possible that we could get together in this particular way, in this particular times. And I wish you a good health to all of us, to all of you. And thank you very much for being with us. And I would be happy if you could see again in a digital way or in a physical way. Thank you very much.